Okay. So the definition then for your book for personality disorders is that they have to demonstrate some type of pathological personality trait. They often do not see themselves as dysfunctional. And often the personality disorders, they co-occur with other things like depression, anxiety, eating, or substance abuse. So there's usually other things that are going on within their life other than just having a personality disorder. So some things that these people will utilize to deal with their personality disorder. The first one is repression. This is unconsciously blocking thoughts or impulses. Then suppression. This is voluntarily blocking thoughts or impulses. Regression, they go back to a time when it was safe. So you might think that, maybe a 30-year-old kind of acts like they're 15 or 16. Maybe times were better then, it was safer, and so they regress. Another thing that they will do is undoing. They shower somebody with a gift or something to try to undo or take back months of treating somebody poorly. And another defense mechanism that they can use is splitting. And what they do here is they categorize you as all good or all bad. So if I'm coming in and Martha's my day nurse, Martha, you are the best nurse, but the last shift was like the worst nurse I've ever had. So it's all good, all bad. It wouldn't have been, oh, she was okay. She was the worst. You're the best, she was the worst. Okay. Some common pathological traits then that they will have one or more of these. Inflexibility or maladaptive responses to stress. Compulsiveness and lack of social restraint. Inability to connect emotionally. Tendency to provoke interpersonal conflict. And ability to merge personal boundaries with others. When you look up personality disorders, they are clustered together. They call them clusters. And they're clusters A, B, or C. So the first cluster, and your book does break down each one of these and talks about them individually. So like I say, if you want a little more explanation as to what's going on with these folks and what they look like, you can read the little section in the book related to that. But in cluster A, they call these the odd or eccentric traits. So the first one is a paranoid personality disorder. They believe people want to harm them, exploit, or deceive them. So they believe somebody is out to get them all the time. Schizoid personality. They're characterized by emotional detachment. They have disinterest in close relationships. They're often uncooperative. Schizotypal or typal, they have eccentric appearance. They have a lot of odd beliefs that lead to a lot of interpersonal difficulties with them. So they have odd or eccentric traits. The second cluster are the cluster Bs. And they call these the dramatic, emotional, or erratic personality disorders. And the first one is antisocial. Their character, they have a very disregard for others. There's a lack of empathy for others. They have repeated unlawful behaviors. They have a sense of entitlement. They can be impulsive, manipulative. They're very charming and engaging. So I was going through YouTube videos, and it's real hard to pick snippets when you have like 9 different personality disorders here. But I watched one was a young man, and he has an antisocial behavior, and he said he has to be real careful. He tries not to socialize a lot because when he finds somebody that's weak and he can prey on, he can't help himself. To manipulate them or cheat them out of something. He said, I'm always looking for the person that's weaker in mind than me, that they can manipulate and charm. And he said, so I don't go out a lot or socialize with a lot of people for fear I will come across somebody that comes across as somebody that's easily manipulated, because he said, I can't help myself but take advantage of them. So that's a pretty mild antisocial behavior, because you have a lot of people that commit heinous crimes are very antisocial. They don't really regret doing it. They don't have a lot of empathy. They're not very sad that they've done it. So these folks are very dangerous people, or can be. Borderline is a splitting behavior that they have. We talked about splitting. You're either all good or all bad. They're impulsive. They have a fear of abandonment, and they have a history of doing self-harm. Histrionic, these are emotional, attention-seeking behaviors. They tend to be very seductive and very flirtatious. Narcissistic, they're very arrogant. They have grandiose views of self-importance, and they definitely lack empathy for others. And they're often very sensitive to criticism. They don't want you telling them that they're wrong or something's not right about them. Okay, so that's the cluster Bs. The cluster C, these are the anxious or fearful traits. There's a lot of insecurity and inadequacy. So this one is avoidant. There's social inhibition, avoidance of all interpersonal relationships, even though they really want one. Dependent, this one's pretty easy to remember. Extreme dependence on a relationship, and once one is done, they'll work very hard to get a new one. And then obsessive compulsive personality disorder, they are perfectionist, they're orderly, they are persistent in the fact that they control things even when tasks may not even be able to be completed because of their orderliness and how they have to arrange the situation or do something so many times that they may not even be able to complete the task. So they have a hard time managing just even small things, getting laundry done, getting the house clean, getting a meal clean, getting to work on time, etc. Okay. Onset in the clinical course. It is relatively common. 10 to 20% of the general population have personality disorders. The incidence seems to be a little higher in lower socioeconomic groups. And 40 to 45% of people with primary diagnosis of mental illness also coexist with some type of personality disorder. So it often complicates the treatment plan. Okay, so 40 to 45% with a primary diagnosis of a mental illness also have some type of coexisting personality disorder with it that they have to try to deal with.
Hey Lisa, our paper says 40 to 50. Which one do you want us to go off of?
Oh, geez. I don't know. I think your slide is correct on this one, the 40 to 45. Your 5% difference isn't going to make or break, because I'm never going to ask you a question on a percentage. Is that fair enough? That's more like a statistics, Taylor, and we don't really test on stats because you're never going to get an NCLEX question based on some type of statistic. It's more just to put it in perspective of a percentage of maybe who it affects, okay? So I think we'll be okay with that. But I'll make it so they match the next time. Etiology for it, there are some theories. One of them is a temperament theory. And the 4 temperaments that we're looking at is harm avoidance. So in other words, I would say I'm in a moderate range for harm avoidance. I drive my car probably a little too fast, but I don't go 100 miles an hour. That would be a low harm avoidance in a patient that had some type of personality disorder or something going on, that there's kind of a recklessness to them. Novelty seeking, again, it can be high or low. Reward dependence. Persistence, those are all 4 different types of temperaments that a person has, and you usually should be somewhere in a moderate range, okay? A combination of highs and lows in different temperaments. But if you're extremes on either side, then that leads into personality disorder issues. And your book goes into that a little bit more on those types of temperament traits that people have, so you can read a little bit more about it. But really, in the end, you want something in that moderate range on all 4 of those temperaments. Makes you a fairly healthy person. But when you have highs and lows in those areas to the extremes, it makes for a personality disorder issue. Highly persistent people are hardworking and ambitious, and you need that. You want that in an employee, right? If you're somebody that owns a business. But if you have low persistence, then you may not care whether you get to a job or not. So there's a fine line between those temperaments as to what makes one healthy and one unhealthy in their behaviors. Then there's a psychodynamic theory. These are characteristics of self-directedness. Are they responsible and have goals? Cooperativeness. Are they an integral part of society? Are they empathetic? Are they supportive? Self-transcendence. Are they a part of the universe? Do they feel fulfilled? Are they humble? Are they spiritual? So they believe that how or who you come in contact in your life kind of determines whether you develop these personality disorders or not. So that looks at your temperament and it looks at your character. So those are two theories as to why they believe personality disorders evolve or come out in people. There are some cultural considerations when we look at personality disorders. Personality is viewed with consideration of their ethnic, cultural, or social background. Some people may be guarded or defensive, possibly due to language barriers or other things that's different about them. Cecilia, in her nature, probably is a little guarded when she's around new people, especially if they would figure out or find out that she has schizophrenia. She would be a little guarded, probably. Different views of avoidant and dependent behavior. Cultural value of work or productivity. So you may not, some cultures may not view it as a personality disorder, but how they're culturally, how they're brought up within their society. Treatment, your book talks about group or individual therapies, cognitive behavioral therapy, some restructuring techniques, dialectical behavior therapy for those that exhibit self-injurious behavior. So they would work on coming up with plans not to self-injure themselves, contracts, those kind of things, so that they don't cause harm. And then case management. You might have to have a case manager for those that are persistently or severely impaired. And I was telling my clinical group, and Mrs. Rose and I even looked up today, we had good VHS tapes that portrayed all of these personalities. And when you see somebody actually behaving in an avoidant or a narcissistic or a histrionic behavior, it kind of ingrains it in your head. Just talking about it is not quite as good as actually seeing it played out. I looked on YouTube again for some good things, and all I see are interviews with a narcissistic, interviews with a histrionic. So you might comb the YouTube field and see if you can find anything, but I couldn't find anybody pretending to be in that state, pretending to be narcissistic and treating their spouse poorly or a family member poorly because they have a very high sense of themselves. But I don't know. They were good and I wish we had them, but see if you can find anything that actually portrays the person actually displaying those personalities, and it would help. So far, I personally have not found anything, but if you come across something, let me know. Medications for our folks with personality disorders, depending upon what they suffer from. Some of ours that are having more psychotic issues might be on some type of antipsychotic or mood stabilizer. Those might be for our erratic behaviors, our cluster A's, your antidepressant medications, your anxiolytics, things that are your anti-anxiety might be for our cluster C personalities where they're fearful and anxious behaviors. So that would help with those folks in dealing with their specific issue. Nursing care, your book does talk about it, and you do have to realize that people with personality disorders are going to look just like us. They're going to, for the most part, behave just like us, but there's going to be some little thing that's off about them. So they can evoke a lot of emotional response from you as the nurse. recognize your own response to these types of patients. Your focus should be on appropriate social interactions within a group. Safety is the top priority, especially since many of our personality disorders are at risk for self-harm or violence to others. But they will push your buttons, so you need to be able to control that. Communication with personality disorder patients. Firm yet supportive approach and consistent. Being consistent. Offer realistic choices to enhance the patient's sense of control. Especially for your dependent personalities, because they think they can't do anything without somebody helping them. Limit setting, especially with manipulative clients like your borderline and antisocial behaviors, because remember we said antisocials are just charmers. Okay, if you look up Ted Bundy, he was nice looking and charming. And then what did he end up doing? He was a mass murderer, correct? Okay, so yeah. Charming and manipulative. Assertiveness training and modeling is beneficial for a dependent or histrionic patient or personality disorder. Your schizoid and schizotypal tend to isolate. You will cause more anxiety if you force them to do a lot of extra things, so be respectful of that, but they still need to participate. But there are going to be times when they want to be left alone, and that's okay. That's just part of their personality. It can't be to the extreme where they can't function in society. They can't hold themselves up in their home and never come out because of that particular piece that they want to isolate. Maintain professional boundaries and communication with histrionic patients or clients. As you read about histrionic behavior, they're very seductive, very sexual. And you have a nice, handsome young man coming on to you, you've got to use professional boundaries. You have a great looking woman coming on to you and, telling you how wonderful you are and how nice looking you are. You have to have boundaries. Monitor for counter-transference reactions and those that exhibit dependent behaviors. So that's in your cluster C's. Those are your fearful and anxiety patients. You've got to watch. For unmet needs, there are things that are going on with the client that you're going to need to watch for. Self-care, appropriate sexual expression, budgeting, psychotic symptoms, are they under control? And what kind of physiological stress? If you care for the first three areas, they will have a greater sense of well-being and improved health because they'll be able to function a little more within society. So on these, I encourage you to look at your clusters, A, B, and C. Have a basic understanding of the different types underneath the clusters. And when you understand what's going on, when you look at a narcissistic and it's all about them, you'll be able to answer questions because you'll recognize the narcissistic person. When you read about the histrionic person and you get a question that talks about the person who's inappropriate sexual advances, those kind of things, you know it's your histrionic patient. When you have an antisocial person and they're manipulative and engaging, and you'll know that it's your antisocial personality. So just have a basic idea of what's going on with those different folks. And I think you should be able to answer questions that are on the test related to that. Okay, our last section then are somatic disorders. And I believe that's chapter 21 in your book. It's a fairly short chapter. Psychosomatic is a connection between the mind and the body. Hysteria is a multiple physical complaints with no organic basis. And that was a proposal by Freud that people can convert unexpressed emotions into physical symptoms. And we do know that's probably true. People that have a lot of anxiety can suffer from migraines and body aches and pains and those kind of things. And then somatization is a transference of mental experiences or states into body symptoms. So it shouldn't really be a comma, should be or states into body systems. Okay. So there are three central features to somatic illnesses. Physical complaints suggest major medical illnesses, but there's nothing organic going on. So you complain about health issues, you have severe whatever, and we've done all kinds of diagnostic studies and nothing comes up. Your labs show nothing, your CT scan or MRI shows nothing, and yet you have this so-called physical problem. Psychological factors and conflicts seem important in initiating, exacerbating, and maintaining your symptoms. So it is a psychological piece that is fueling the symptoms that you have and the maintaining of them. Symptoms or magnified health concerns are not under the patient's conscience control. So they cannot control that. What are some risk factors? Well, a first-degree relative that has a somatic disorder, you also could have a somatic disorder. You might have decreased levels of serotonin or endorphins. It may coexist with a depressive disorder, a personality, or an anxiety disorder. There is also a correlation with childhood trauma, abuse, or neglect that can cause somatic disorders. And it tends to run more in females ages 16 to 25. Findings for patients with somatic disorders is the somatic symptoms do disrupt their everyday life. They have an excessive preoccupation with those symptoms. They have anxiety about them. They can have remissions and exacerbations of their symptoms. Because in their mind, their physical ailment is real, they can suffer from alcohol or substance abuse. They tend to be over-medicated with analgesics or anti-anxiety medications. And they have to have those symptoms for longer than 6 months. there are some cultural considerations, and they're variable in their frequency and their meaning across cultures, but you can read some of those. I'm not testing you on those, just know that there are cultural beliefs, and there's some interesting ones on that table when you actually read about those different cultural pieces and what they mean. In that dot Menon society, men in India, they have a hypochondrial concern about semen loss. In the Koro in Southeast Asia, the belief that the penis is shrinking and will disappear into the abdomen, resulting in death. I mean, you and I would think, what the devil? I don't think that's going to happen, but in the falling out episodes, it says you can see that culturally in the southern United States or the Caribbean islands, there's a sudden collapse and the person cannot see or move. So like a temporary. Let's see. For Koreans, suppressed anger causes insomnia, fatigue, panic, indigestion, generalized aches and pains. So there are a lot of cultural things that go on throughout the world that we may not have a very good understanding of, but those are also things to look at when they're diagnosing somebody with somatic disorders. Treatment, you do have to accept that the symptoms are real to the patient. You do want to assess for suicidal thoughts, especially, if they've been told repeatedly that it's all in their head. Limit discussion time on their symptoms. Don't let them dwell on them. Encourage independence and verbalization of their feelings. Encourage physical activity because it does increase endorphins. So they may actually feel better the more activity that they have. And I have one more dot to include, or a number 6. They can use antidepressants with these. And also, you can either make it another dot or number 7. Sometimes referrals, because pain seems to be a big issue symptom-wise for these people, you could refer them to a pain clinic for treatment. Okay, so antidepressants, and then you can make a number 7, pain clinics sometimes are helpful. There we said there's the pain clinics, referrals if need be, information about community support groups, and then try to promote some type of pleasurable activity or hobby, something to kind of take their mind off of their somatic symptoms. So information about community support groups, and then trying to get them to engage in some type of activity or hobby. Mental health promotion, assess patients' ability to deal directly with their emotional issues. Some are better than others. Assist patients to continue gaining knowledge about themselves and their emotional needs. First they have to recognize that there's an issue, and then they have to gain control over their emotions and to be able to deal with their somatic illness. Self-awareness issues, they have to deal with feelings of frustration, be realistic about small successes, validate the patient's feelings, deal with feeling that the patient could do better if he tried. So these are all things that you as the nurse or the family member has to deal with when you're dealing with somebody that has somatic issues. Because you've been to the doctor with them 29 times and they still haven't found anything, but yet they still have this pain or this whatever that they're complaining of. So you can imagine how frustrating that would be to be their physician, to be their family member when they've been told nothing's wrong with them. There are a couple other disorders that can happen under the vice of somatic disorders. This is conversion disorder is a neurological disorder. It manifests itself in an alteration in voluntary motor or sensory function. So for motor, they could have paralysis or seizure-like movements or gait issues. For sensory issues, they could have blindness, their inability to speak, maybe they can't smell, numbness, or maybe they can't hear, deafness. And one other type of conversion disorder is a false pregnancy or a pseudocyesis, and this is due to an extreme desire to be pregnant. So they actually will have a false pregnancy. And there you have to write down, yeah. So paralysis, seizure-like movements or gait issues. Sensory is blindness, inability to speak, smell, numbness, or deafness. Risks for people to have a somatic disorder or this conversion disorder would be abuse, recent acute stressful event. Maybe you've had a child that's died or something, or you were very close to your mother or father, or your spouse died, maybe traumatically or unexpectedly, and you didn't have time to deal with the impending death. It just was very acute. Female tends to run more in females. Comorbid psychiatric disorder, so it can run in tandem with something else, or also a first degree relative that has a conversion disorder. So abuse, recent stressful event, female, comorbid psychiatric disorder, and then a first degree relative. And these people seem to have what they call a labile indifference, a lack of concern or inappropriate calmness about their illness. Okay, so a labile indifference. They have a very lack of concern or an inappropriate calmness related to their illness. Fictitious disorder. This was previously known as Munchausen syndrome. They report physical or psychological symptoms to gain attention. Sometimes they'll even harm themselves to be able to show up at the emergency room and say, oh my gosh, look what's wrong with me. Or they can have a fictitious disorder imposed on another. And there's several movies out there related to mothers who lie about child symptoms, or they create illnesses in their child by feeding them certain things to make their child sick so that they can gain the attention from it. Or they fake a cancer in their child to gain attention from it. So there's several movies out there about that. And then it is different from malingering. Malingering is done for personal gain. So you pretend to be ill to get disability benefits, to avoid military service, something of that nature. That's malingering. That is not a fictitious disorder. Okay, so that's a little different than the above.